Good evening, all. I'm Dr. Fatouma Lo, currently a comm-serve at Rahima Musa Hospital. And today I'll be speaking about poisonous plants in South Africa. I do think this is an important topic and discussion to have, especially as doctors that work in the emergency department, as this should be a diagnosis we have at the back of our minds when patients present. And it's not necessarily about identifying the exact plant, although that would be great and will definitely help you. And we do have resources in place for that. But it's about having a good approach to possible toxic ingestions and directing your management accordingly. So with toxic ingestions and poisonings in general, they tend to occur in two ways. With young children, this is often incidental. It's often from just being quite inquisitive, exploratory behavior, where they tend to ingest parts of household plants. Good thing is often when these plants taste bad, they tend to spit them out. So often the ingestion is quite minute and they tend to not have very severe symptoms. Whereas with adults, it's often intentional ingestions, especially amongst adolescents, if they have found out that certain plants can have, for instance, hallucinogenic effects, which they want, or in cases of adults, misidentification of certain plants such as mushrooms. Also with animals, often is incidental ingestions because they see very bright colored flowers, lilies or seeds on the floor. And often in veterinary medicine, this is often quite a common presentation. Toxicity is often greatest with certain types of plants, and these are ones that contain calcium oxalate, alkaloids, or your cardiac glycosides. And I will be going into depth with these plants later on. And in the South African context, it's quite important that we address this because majority of the population do consult traditional healers, and most traditional medicines can contain substances of plant origin. Although most of these are generally not associated with prominent or significant side effects, some traditional medicines can contain potent pharmacoactive substances, so it's often a good differential to have and to do comprehensive and detailed history taking. There can be some difficulty with plant identification, so sometimes having a digital image is quite helpful. Sometimes patients can bring these little plants in bags, so just to look at it, make sure you don't touch it and have adequate PPE and contacting the Poisons Information Center. So general approach would be good history taking, trying to identify that plant, finding out about the quantity ingested, duration that has lapsed, for instance, that will play a role whether we consider giving them activated charcoal, for instance, whether it was a single or multiple ingestions, because often patients do take an array of substances. Doing a comprehensive physical examination. Here we are trying to possibly look for features in keeping with toxidromes, as this will sort of help guide our diagnosis and management. Often starting with a full set of vital signs from arrival at the facility, including your temperature and your HGT, assessing ABCs and intervening accordingly based on what you have found, looking at skin, bladder, bowel function. For instance, if you know patients are quite dry with urinary retention, absent bowel sounds, and you're thinking more, for instance, anticholinergic. Neurological examination. Often patients can present with a GCS of 14, 15, confused, hallucinating from psychoactive substances. And like I had mentioned, a comprehensive head-to-toe exam. So this is just showing you some of the toxidromes that we can consider with our poisonous plants. For instance, with the anticholinergic, we know that these patients can present with elevated blood pressure. They can be quite tachycardic, quite pyrexial to touch. They can complain of blurry vision from the mydriasis and the pupil dilation, often have absent bowel sounds, this urinary retention, quite dry. So just sort of having approach and just sort of expecting certain features with the toxidromes. This is just another image showing the same thing. In terms of investigations, this is also not a one size fits all. You have to tailor it according to your patient and the severity with which they do present. But I do think a good baseline or basic investigation for everyone would be a blood gas, because with this, you can assess your acid-base status, look at the electrolytes. Often, most of them that do present with dehydration can have a metabolic acidosis on the gas, and you can direct your fluid management in that case. 12-lead ECG, looking for any particular patterns that might guide you. chest X-ray for certain patients. For instance, if you are suspecting possible radiopaque toxins, this might help you see drug pockets if you're concerned about an obstruction, bowel obstruction, anything like that. And then baseline bloods, particularly for certain patients, LFTs, especially for toxinous or poisonous mushrooms, that can go with an INR PTT, your UNE for patients that might be oliguric, you are concerned about renal function, and patients that might have intense convulsions, poor urine output, you can consider doing a CK if you are concerned about rhabdo. Again, tailored according to your patient and how they present. A tox screen, bloods and urine, also searching for illicit drugs, but important to consider that you can get false negatives and you shouldn't be totally reliant on your tox screen because in patients that do present quite early, tox screen may come back negative. So this possibly doesn't project very well. It's actually a screenshot from Life in the Fast Lane. I found this very informative. So it's just showing you a general approach to ECGs and toxicology. So looking at the rate, looking at the rhythm, do we see a brady? Do we see a tachy? Are we suspecting an AB block? In which case you're thinking more cardiac glycosides, looking at your QRS duration, your axis, QT interval, any features of ischemia. So just having a good approach and making sure that we do not miss anything and also just preventing first closure bias. Management, so we have our A, B, C, D, F, G for this. So ABCs, as I had mentioned, as part of your initial assessment of the patient, and then intervening accordingly following your routine resuscitation, decontamination, and always remembering personal protective equipment as well. And as much as we want to help the patient, we also have to protect ourselves. Enhanced elimination for patients, particularly presenting usually within 2 to 4 hours, we can consider giving them activated charcoal. Finding the antidote. You'll see as I present going further that certain plants do have antidotes. However, we don't have that in South Africa. And I think it's also nice to know that evidence and studies have shown that in most cases, supportive management is adequate and we don't necessarily need that antidote. Getting help as soon as possible. We can contact the Poison Information Center. So that is the number over there. And for instance, at Helen Joseph, they do have this Afratox database that can help you get information on the plants, not only the plants, but in general about substances, drugs, and also helping you with management of these patients. So activated charcoal, as I had mentioned, this is used for elimination, gastric elimination. So basically preventing that GIT absorption, preventing systemic absorption, and this is administered as a slurry. So in adults, we usually do 50 to 100 grams, diluted and mixed in 250 mils of water. In children, half of that. And in infants, we do 1 gram per kilogram. Important to note that there are certain contraindications, airway compromise, so patients that are presenting with an altered level of consciousness. In the case where you have not yet secured the airway with a tracheal tube, for instance, then you can't give the activated charcoal. However, if these patients are intubated, you can insert a nasogastric tube and you can administer the activated charcoal. In patients with the known GIT motility disorders or, for instance, bowel obstructions, it is contraindicated. And also depending on the type of toxins. So studies have shown that activated charcoal tends to work best on your non-polar and your poorly water-soluble toxins. So things like metals and certain ions, it does not really work. Okay, so now moving on to our poisonous mushrooms. There are quite a few species of mushrooms, and of these, only 100 of the thousands of mushroom species have been shown to be poisonous. And of these, only a select few are actually quite fatal. Often these are categorized as to those that present early and late. So early is often within 6 hours. These patients tend to present with GIT symptoms. Prognosis is often quite better. They often are self-limiting, clear up within a few hours. However, some patients can present early and have this worsening progression of symptoms. So you still need to use your discretion and assess patients on a case-by-case basis. Late presentation, often after 6 hours, can present up to 48 hours after ingestion. These ones are often quite sick, and often the culprit is your Amanita phalloides. And of the toxic mushrooms, the Amanita phalloides is the most lethal. So this is a nice table showing you the clinical syndromes and mushrooms that you can suspect. So within 6 hours, you can, for instance, see our psilocybins, which is a hallucinogenic mushroom, we can also see that most of them presents with gastrointestinal side effects, and you can see that most of the patients tend to have spontaneous recovery and don't really need admission. After 6 hours, like I had mentioned, we tend to have our Amanita phalloides. So often these patients will tell you that they were at home, they had gastro, it resolved, and they thought they were getting better, but actually they just felt a lot worse. So the Amanita phalloides is known as your death cap mushroom. It's responsible for 90% of poisonings, and it may be fatal in up to 50% of cases. It is found throughout Southern Africa. It usually develops under your oaks, pines, and poplars, often after your summer and autumn rains. So you can see that it tends to have this olivaceous yellow-green colors of your cap surface. It has this wide lamelligeal and stem that's quite long, has the surrounding membranous ring, and below ground level, you have this bulb. So in terms of the pathophysiology, it does contain three main groups of toxins: your amatoxins, velotoxins, and your virotoxins. Of these toxins, your alpha amanitin is the most lethal, and essentially it inhibits your RNA polymerase 2 binding to your hepatocyte. As a result, it slows down your protein synthesis and your messenger RNA synthesis, resulting in hepatotoxicity, hepatonecrosis. So your liver is the main target organ of toxicity, but it can also affect your kidneys. So this is just an image showing that you consume it. It's readily absorbed in the blood. After that absorption, it accumulates in your liver, where it binds to that RNA, where it binds to the polymerase 2, and then it inhibits your transcription, resulting in hepatonecrosis. So usually there are three stages of presentation. Early stage, which is the first 6 to 12 hours. So patients present with those GIT symptoms. They tend to have nausea, vomiting, abdominal cramps, profuse watery diarrhea. So they may have signs and symptoms of shock or just dehydration. They can have a tachy. They can be hypotensive. If you do your gas, you can possibly see electrolyte derangement, metabolic acidosis. Second stage is usually 2 to 3 days after ingestion. So here, patients seem to have apparent resolution of GI symptoms, but they are actually experiencing ongoing liver damage. So if you do LFTs in this case, you may see deranged liver enzymes. They can have elevated bilis, can have deranged INR, so they can have coagulopathies, jaundice, and in extreme cases, it can progress to hepatic encephalopathy. Third stage, so continuously ongoing liver dysfunction, but now your kidney is also involved. They can have hepatorenal syndrome. And in most cases, this is often quite fatal, and death can occur in 3 to 7 days. So management for the Amanita phalloides, there is no specific antidote. It is mainly supportive. So correcting those electrolytes, giving fluids, replacing the glucose. Patients that may be very agitated, benzodiazepines play a good role. Activated charcoal for that gastric elimination if they do present within 4 hours of ingestion and they don't have any of those contraindications. Your NAC, your N-acetylcysteine, has actually also been shown to show some benefit in administration, especially for patients that present an acute liver failure the early stages, as well as your high-dose penicillin, so 1 million units per kilogram per day as an infusion. And basically, this acts as a receptor site competitor in your hepatocytes, so it prevents the binding of your alpha aminotoxin. Like I had mentioned, the benzodiazepines, dialysis may be beneficial in patients with renal failure. And in worsening cases, they can be referred to a transplant center such as Donald Gordon in our case for liver transplantation. So this is just showing you an overturned mushroom to show the gills and the stripe. And there you can just remember that it has this olivaceous dark capsular surface. Another group of mushrooms we have is our psilocybins. These are less toxic, but important to note. Often known as magic mushrooms, we tend to have three. So this image is of the natalensis that was discovered in KZN in 1995. So the psilocybins tend to act on your serotonin receptors in your prefrontal cortex. This often presents with hallucinations. In terms of the palliative care and alternate medicine, they have been showing that it can actually be used for medicinal research to treat a range of psychiatric and behavioral disorders. However, according to the Medicines and Related Substances Act, it is a Schedule 7, which means that it hasn't been approved for medicinal use. But yeah, it's mainly used in the palliative care department as supportive management. So that was the Natalensis, and now we have the Maluti. So this was discovered quite recently. It was 2021. It was found growing on Kalminia in the Free State Province of South Africa. So these ones tend to have this elongated, sort of pokey golden caramel cap, and it has been used by the Basotho clan. So what happens is they prepare a concoction, you drink that, and you essentially go into a trance, and traditional healers use that to foresee the future. Next one we have is Ingeli that was discovered last year in 2023. This was actually found in KZN, found in bovine manure enriched grassland. So here we see that they have these very long, thin stems, and they have these gills as well, which are light colored, and they tend to have this dark cap. So adverse effects, it is a hallucinogen, so patients can present with hallucinations usually within 30 minutes. It has been shown that it's not necessarily specifically auditory or visual hallucinations. They just tend to sort of have a distorted perception of items or objects that are already in the room. They can have GIT side effects, nausea, vomiting, or diarrhea, CNS, so that hallucinations can progress to altered GCS, headaches, loss of balance, impaired memory loss. They can have intense anxiety and paranoia, in which case the benzos will play a good role, elevated blood pressure, muscle spasms, convulsions, and in severe cases where these are sustained, they can develop rhabdomyolysis. So doing a CK, UNE, and doing adequate fluid resuscitation is quite beneficial. We then have our Datura stramonium. So this is known as Jimson weed, devil's trumpet, angel's trumpet, maltbitter, which translates to mad seeds in Afrikaans. So this is commonly found throughout South Africa, frequently seen on your roadsides, your rubbish heaps. All parts of the plant are poisonous, especially those black seeds that can contain up to 0.2 milligrams of atropine. Onset of symptoms usually occurs within 30 to 60 minutes and may persist up to 24 to 48 hours. And this is purely because of that delayed gastric emptying as an anticholinergic side effect. So it does sort of stay in your bloodstream for quite some time. These patients present with an array of side effects. So we think mad as a hatter, they can have CNS effects, and this may progress to seizures, comatose state. They are often quite dry. They're often quite pyrexial. They have urinary retention. You can have absent bowel sounds, delayed gastric emptying. Rhabdomyolysis is a possible complication, like I had mentioned, from those convulsions. And again, management is purely supportive. Antidote is physostigmine. However, this is not readily available in South African context. I think a debate that is often had is, can neostigmine be used as an antidote? And the literature has shown that supportive management is best, and the neostigmine isn't really beneficial. So we stick to the supportive management. So this is just showing you that it tends to have this egg-shaped seed capsule, and that is where those seeds containing the atropine are. So this is a mature one. It has opened up where it splits into the 4 chambers, but earlier on it's often closed, and you tend to see that it tends to have these spines or spikes, but sometimes it can be bald. And here we can see the flowers. So we see the stem that is green to purplish in color. It has these coarsely toothed leaves. It's often white, can be yellow as well. It's often solitary flowers. You don't find them in clusters, quite large, tubular. And you can see these shallow lobes, and these ones usually bloom at night and often do emit quite a nice fragrance. And it's important to distinguish this from Brugmansia, which is our moonflower. So these ones are often also trumpet shaped. The Datura stramonium is also trumpet shaped, but these are large, drooping, tend to face downwards. They range in color. So here we have peach, often found in pink, but they can also be found in white. They can also be found in yellow. So sometimes they are confused for the Datura stramonium. They bloom at night, emitting this very, very pleasant fragrance. All parts of the plant are highly toxic. They contain eutropine alkaloids, so your scopolamine, hyoscyamine, and atropine. So they can trigger anticholinergic side effects. These plants have been used mainly by teenagers, adolescents for this hallucinogenic effect. Symptoms, onset of symptoms is usually within an hour and can persist up to 48 hours again because of that delayed gastric emptying. Moving on to our melia. So this is often referred to as our syringa tree, syringebum, or China berry. So we tend to have medium to large trees that produce these clusters of these yellow berries that are highly poisonous. They can also have lilac-like flowers that are also held in clusters. The berry has a very dark kernel, so mainly causes symptoms when chewed as opposed to when just swallowed, because that's when you release the melia toxins. And these melia toxins act as enterotoxins and neurotoxins. Um, so in terms of enterotoxins, you tend to present with your GIT side effects. So they can have cramps, vomiting, diarrhea, which may be bloody or not. Animals can present with hypersalivation if they do ingest these berries that may fall onto the ground. Neurotoxin side-like effects, they can have ataxia, seizures, depressed state, paresis, coma, and if left untreated, it can progress to death. Management is again symptomatic, supportive. So this is just showing you the trees. You can see the clusters of those yellow berries as well as the lilac flowers. Okay, now we move on to our Nerium oleander. So this is an invasive species commonly found in the Eastern Cape, KZN, as well as Mpumalanga. Very beautiful flowers that have these attractive pink, white, yellow colors. All parts of the plant are also poisonous. And here, the pathophysiology is that they contain your cardiac glycosides, resulting in positive inotropy. And essentially, it works on that sodium potassium ATPase pump. It inactivates that. As a result, you have an influx of your intracellular sodium as well as your potassium, as well as your calcium. And then you have a release of your extracellular potassium, and that can actually cause lethal hyperkalemia. So it causes positive inotropy and causes negative chronotropy. So these patients tend to also present with bradycardias, blocks as well. So clinical presentation, they can have severe headaches, visual disturbances where they have a misperception of colors. They tend to see halos as well. They can have GIT side effects. If you come into contact with the sap directly, it can cause contact dermatitis, bradycardia, and heart block from the negative chronotrope effect. In severe cases, it can progress to VFib. It can progress to asystole. They can have elevated serum digoxin levels. And management in this case would be close cardiac monitoring. So with these patients, it's quite important to distinguish digoxin-like effect from digitalis toxicity. So digoxin effect isn't the same as the toxicity. So this is just meaning that they have therapeutic levels of the digoxin. And here with the ECG, they tend to have this concave, slurred ST segment that is often referred to as a reverse tech or your Salvador Dali mustache. And with the toxicity, they can actually present with varying degrees of arrhythmias. Some may be fatal. Management is mainly supportive, so close cardiac monitoring, even in the case of toxicity, doing expectant management. And in certain facilities, which we don't have in South Africa, there is the digoxin immune fragmented antibody that can be used for life-threatening conditions as an antidote. Moving on to plants containing our calcium oxalate crystals, we tend to have four in this group: our dumcane, elephant's ear, the arum lilies, and delicious monsters. So these are popular exotic plants, tend to affect pets more than animals, more than humans, because they usually pick these up from the floor. often present with an immediate intense pain of your lips and oropharynx. This may, in certain cases, in severe cases, progress to laryngeal edema, where you can have airway compromise, and our patients do need to be tubed or have a cric. The SAP may cause contact dermatitis or keratoconjunctivitis if they do end up rubbing their eyes or touching their eyes. And here, management is essentially trying to just cool the area. So clear the area, wash it off, administer cool liquids, or making the patient suck on crushed ice. So in terms of the elephant's ear, you can see from the image, it has this very lush, dramatically lobed leaves, hence alluded to the elephant's ear. And with these ones, they can contain as much as 0.7% of calcium oxalate. So often that burning sensation and that numbness they experience is quite severe. In terms of the spotted dumb cane, these ones tend to contain your needle-shaped calcium oxalate crystals called raphides, which also cause quite a painful oropharyngeal sensation and that tinge. So in terms of identifying these plants, you can see that it's more like a tall, straight stem. They have these simple leaves that have alternating white spots and flecks. In terms of our delicious monster, these ones tend to look like your green ear of a maize covered with your hexagonal scales. They also have lush foliage, very big leaves that are often segmented. And then in terms of your arum lilies, these are native to Southern Africa, particularly Lesotho, can also be found here, and Eswatini. So these have very large, very showy white flowers, very beautiful, so often ingested by animals as well. Commonly found growing along stream banks and your ponds margins, so anywhere where there's quite good water flow. Yeah, so we've reached the end of the presentation. We're just going to have a quick case presentation just to see if you guys have been paying attention. Okay, so we have a 29-year-old man brought into the ED by his partner and accompanied by the police. History provided is that he was found hysterical, breaking household dishes about an hour ago. The wife had to call the police in order to come him down, bring him in. She reports no background medical history, previously a healthy man, but she brought a picture of a plant that has this big white bell-like flowers and indented leaves, which she found in the kitchen, but she was scared to touch. During the examination of the patient, he's quite agitated, disorientated, GCS 14-15. He's speaking in quite a bizarre way. His skin is quite warm to touch, red, dry. His pupils are dilated. His clothes were also noted to be clean with no visible soiling, so he's not pouring. There's no vomiting, there's no diarrhea. He's tachycardic, has a heart rate of 118, pyrexia 38 degrees, rest rate is 24, and slightly hypertensive, BP 153/90. This is the picture the lady has on her phone. Question is, what is your approach and what plant do you suspect? Beginning of the slide, we've gotten our history, we have our vital signs, we've examined the patient. Let's start off with, is anyone suspecting any particular toxidrome?
Claire, are you able to take this one?
Yes, sure. So I'm suspecting it sounds like an atropine. There might be an atropine. I'm not quite sure what the correct term is, but yeah, it definitely sounds like an atropine in toxicity. He's got those anticholinergic symptoms. But in terms of an approach, I always start with A, B, C, D, E, F, G. So his airway seems to be patent because he's speaking in a bizarre way. He's breathing, his rest rate is 24 breaths per minute. C, circulation, so his BP is 153/90, so I'm not too concerned about that, but I would still put up an IV line for IV access. D, his GCS is 14/15. I would check his glucose at this time and start supportive management.
Great. Excellent. So Claire has correctly identified that we are thinking anticholinergic toxidrome. We can see from the fact that he's pyrexial, he's red, he's dry, he's got this pupil dilation. They've mentioned that his clothes are clean, so we're not thinking any vomiting. So we're thinking more delayed gastric emptying. He hasn't soiled himself. And always the ABCDE approach. and intervening accordingly based on what you see, and then supportive management. So you'd probably do a gas just to have a look at the fluid status. He is quite calm, even though he's a bit disoriented, so I don't think he needs benzos in this case. So yeah, guys, it's not really about identifying the specific plant, but just having a good approach. If you can identify a toxidrome and then providing accordingly supportive management. But Claire, do you maybe want to take a guess at what plant this is, since you did so well with the approach?
Oh my gosh. I want to say moonflower because you said it's a trumpet shape, but I don't remember, and I'm terrible at botany. But I think it looks, only because it's white, I'm guessing moonflower. I might be wrong.
Okay, great. So it's actually the Drommonia sporonium, so Deuteria stramonium. And I did mention that that's often confused for white flower because they both are trumpet shaped, as you have correctly identified. But I don't know if this is supposed to help you, but these ones tend to face upwards, other ones tend to face downwards, but they do essentially look the same. And your management is the same regardless of whether you've identified it correctly or not. So I think it's about identifying a toxidrome, intervening accordingly, providing supportive management, and you will still have the same outcome. So thank you so much for that, Claire.
So, Fatouma, thank you so much for this presentation. I really appreciate it, and I look forward to actually going through it again. What's interesting to me is the number of these plants that are house plants, like the monstera and as you were going through them, I was like, oh my gosh, I've actually seen, I mean, there's a picture of one that's in a pot plant, and you can see it's in somebody's home. And so that is concerning to me. You know, it's not that people need to go out into the bush or out into the wilds to encounter these, but rather that they can be at home or in somebody else's home and encounter and, you know, have contact with them. So, yeah, you know, it is concerning to me.
Yeah, no, definitely. I think as I was also doing the research and looking at everything, I was like, wow, I've actually seen these flowers before. I might have even touched them. So yeah, it does show that these flowers are often in our homes. That's why the pets and children are often affected by these because, you know, they just tend to explore, touch everything. With us, it's maybe like dermatitis from touching them, and then we know that we should handle it with gloves. But yeah, like you've correctly identified, we don't actually have to go out to the bush. It's often in our homes.